Scott, welcome to episode 11.
Hey, Mark. Great to be with you today.
Well, today's an important one, obviously, and we have an incredible guest. But of course, first we have to do the disclaimer. You want to do the honors today?
Yeah, can I jump in this time? Thanks. Yeah. Well, of course, as always, the views and opinions expressed on this podcast are those of the co-hosts and guests and do not necessarily reflect the views of sponsors or any of its affiliates.
Great. Well, today is a special episode in many ways. One, it's probably the most timely topic that we have in the industry right now. And that's related to the access challenges related to all the obesity medicines. We have one of the nation's foremost experts, Dr. Angela Fitch, is joining us today. She's the co-founder and chief medical officer of Knownwell. She's the president of the Obesity Medicine Association and faculty at Harvard Medical School as well. And in one of the small worlds, like this was all meant to be, even though we were introduced through another third party, it turns out that Angela is married to my partner Bob and his wife's Sarah's nephew. So she's part of the family, believe it or not. How about that?
I love it.
Well, we're happy to have you with us, Angela, for all those reasons.
Thank you so much. Yeah, thank you. It's a pleasure to be here. I'm excited to be here.
Great. Well, it is an important topic, and I do want to start with the fact that you are an obesity medicine sort of specialist, and that's a relatively new specialty that more physicians are focused on. So can you sort of share with us how it's all evolved over the last, or first for you, a couple decades, but how it's all evolved over the last decade as well?
Yeah, thanks, Mark. And again, it's a pleasure to be here. This is a timely topic, as you mentioned, but also not really a new topic, right? I mean, it's getting a lot of new attention, which it rightfully deserves, because for probably the last 15 years or so, we've been really as an organization. The Obesity Medicine Association actually was founded in 1950. That's 1950. Wow. So that's how old we are as an association of clinicians that practice obesity medicine. So people have been practicing obesity medicine for quite some time, despite the fact that we haven't had these newer medications that we have today that are so much more successful at creating, better outcomes, right? And so again, we've been doing this for quite some time. Myself personally, I've been doing obesity medicine full time since about 2011, 2010. I started in primary care. And, as I was working with primary care patients, both internal medicine and pediatrics, so I do also treat adolescents with obesity. Over the course of those years, people would come in and they'd ask me, like, how do you lose weight? I need to lose weight, right? And it was one of those things as a doctor, even, back in my early days in the early 2000s, when I got out of residency, I'd be like, I don't know, Weight Watchers, Jenny Craig, go exercise a little more. I mean, track your calories. And that was partly because, we didn't have much education in metabolism or in obesity, because despite the fact that we knew some things about it, we just really didn't know as much as we do today. The advancement of the science around the understanding of the biology and the physiology of obesity as a disease state has dramatically increased, since even over the past 10 years.
Yeah, very interesting. Angela, could you tell us a little bit about your work with Knownwell and also with the association?
Yeah, so I have been practicing, like I said, initially primary care and then obesity medicine. I've largely been in large academic and large health systems my entire career. So I've really been, more focused in the large health system academic space. And so most recently, I moved out to Boston to be at the Mass General Hospital and be the director of their very large and old weight center. The Mass General Weight Center has been around for 20 years, actually. So it was one of the first integrated weight centers in the country that combined bariatric surgery with obesity medicine, and so really was comprehensively treating patients with obesity. But as that sort of evolved, for myself personally, during the pandemic, I was contacted by my co-founder, Brooke Boyarsky-Pratt, who is a very successful businesswoman, but also is a patient with obesity. And she found that, every time she would move to a different city or different place, she'd have to find an obesity medicine clinician, which typically took like maybe a year of wait list, to get into one of these academic centers. And then she would have to find a primary care physician that wouldn't sort of chastise her for the fact that she was still struggling with her weight despite the treatment she had had. And because it is a chronic disease and we really have to treat it as a chronic disease. And most people aren't. They're sort of thinking about it in a shorter term format, right? In a sort of like a diet related format or a diet culture type of format, right? Just eat less, exercise more. You should be okay. You should be able to fix this on your own, right? And that's what she kept getting and hearing all the time, throughout the course of her journey with obesity. So she decided to, she had this idea of we should create a clinic that's specially designed, for people with overweight or obesity, or even people with metabolic health issues, which is a separate discussion we can have, where they can come and not feel stigmatized, where we can say, we're going to not blame all of your other diseases on your weight, right? She frequently tells a story about she went in to the doctor and she has a sinus infection. Someone said to her, well, if you lost weight, you wouldn't have as many sinus infections, which we have no, like data around, had nothing to do with her weight. She had, a virus or a sinus issue, right? So again, she really was passionate about creating this comprehensive longitudinal medical home for people with weight struggles in our country. And that's what we did at Knownwell, and that's what we've created.
Well, that's amazing. That's great. And so what can be done to help sort of foster more physicians and create, an environment where there's, as you said, there's this less stigma associated with seeking out treatment and finding doctors that know what they're dealing with.
Yes. So, and as Scott mentioned, my work with the Obesity Medicine Association, I think this fits nicely there because, like I said, we are an association that started back in 1950, actually, as the American Society of Bariatric Physicians. But when we decided to rebrand ourselves, I think it was about 10 or 12 years ago. I can't remember exactly the time when we rebranded. But when we rebranded to the Obesity Medicine Association, it was because we were really recognizing the complex care team as well, because we didn't want it to be just a physician, a place for physicians to come and get support, but we wanted to expand it to be able to include the entire care team. We're talking dietitians, psychologists, nurse practitioners, physician assistants, so we want to be, a support for all of those different, people on the care team. And it really is important, to educate, our own colleagues, right, about the disease of obesity, because we don't get a lot of education, whether it's in nursing school or nurse practitioner school or pharmacy school or any of the medical schools. And that's what we're really working on at the Obesity Medicine Association, is to educate people on the disease of obesity and how can it, be treated in a less stigmatizing, in a more comprehensive care pathway, including medication, surgery, nutrition, physical activity, and behavior, because all of those things are components, just like they are with heart disease or with hypertension or diabetes or any other chronic disease. So that's the work we're doing there is really to reduce that stigma and bias. So if patients are looking for someone, we do have a find a clinician tool on our Obesity Medicine Association website, as well as we work closely with the Obesity Action Coalition, which is the patient advocacy arm for obesity here in the United States. And so you can go to the Obesity Action Coalition's website too, and they also have a find a clinician page that helps people find people who may be more tuned into this, as a chronic disease.
And Angela, is there anything being done, or can anything be done to try to recruit more medical students or residents or early physicians into the specialty? Would that help?
Yes, we're doing that right now. Actually, there's a big education effort that is being launched within identified pilot medical schools, to really do more education on obesity. We have at the Obesity Medicine Association, we have a clinician in training pathway. So we have many clinician in training members. We try to encourage people to join. It's actually, only $25 for them to join. So it's a very minimal fee to join, but that, gets you a lot of resources and a lot of free education on obesity topics. So we have a nice education page with an academy with a bunch of recorded learnings, et cetera, a lot of which are available, if clinicians are members. So we're really trying to do a lot of advocacy work to reach out to medical schools and get this, into the curriculum, because it's very challenging to get things into the curriculum in medical school because there's so much that needs to be covered. But again, we're trying to figure out ways of weaving that in more and more over time.
Well, just to follow up, in the meantime, given that there aren't enough physicians for the need, I wonder, especially, in a pandemic, post-pandemic world, what has telehealth changed patterns of care or improved access for care in this area?
So that's kind of an interesting double-edged sword, right? Because I think on one hand, it has, increased people's access, especially people with obesity who would oftentimes have to travel for great distances to get to an obesity center, right? Whereas now they can do, remote visits and telemedicine visits. And the disease of obesity, just like diabetes and other types of chronic diseases, can be fairly well managed virtually, right? With enough, clinical information added on, labs, people can go to a lab facility now anywhere in the country, right, and get their blood work done. So I think the idea is that while it's opened up a lot of access, it also has opened up for a lot of other types of telehealth that might not be quite as comprehensive. And that's one of the concerns we have, nationally, is that, this is a in-demand treatment right now. And with 140 million people in the country that qualify for treatment for obesity, I think that it's easy to sort of say, I'm going to open up a clinic that you're just going to text me your information and I'm going to text you a prescription back, right? Which I'm not sure, we don't feel like that's comprehensive enough to help people with a chronic disease that they're trying to manage. That's sort of treating it as if it's a very sort of, contractual type of interaction, when it's a very, it's got a lot of psychological and other types of overlap that need to be addressed, again, just like other chronic diseases.
Well, speaking of in demand, the GLP-1s are in the headlines, and so obviously they seem to be having some dramatic results. What's your perspective on those therapies?
So, GLP-1s, right? I mean, I remember prescribing the first GLP-1, back in the early 2000s for people with diabetes. In fact, I was and a team of people at the University of Minnesota, we were one of the first people to study adolescent obesity with GLP-1 use. This was back in 2010, before we didn't even have any, we had no GLP-1s for adolescents. We didn't even have, I think at the time, we did have Saxenda was not, liraglutide for obesity was not even available at the time that we did the study. We did the study with Byetta because that was the drug that we had available. And so again, we were looking at this back in 2010 saying, hey, this is going to help even adolescents with obesity, to find treatment. So they're a very effective tool, for obesity management. And they're our most effective tool today, for obesity treatment, other than surgery. Our most effective medical treatment, I should qualify, for obesity, because surgery is still our most effective treatment. If you look at just treatment efficacy in aggregate, when you look at outcomes of patients, being treated with X, Y, or Z type of intervention, which is what we do in medicine, right? We look at treatment X, treatment Y, treatment Z, right? We say, which treatment is going to be best for you. Unfortunately, in obesity treatment, we don't always do that shared decision-making discussion with patients, and especially now that there's been so much press and headlines, around the newer GLP-1s, are most exciting because of their big jump in efficacy. So if you look at our older GLP-1s, which is liraglutide, for example, about 10% of patients were able to lose 20% of their weight, with that treatment. Right? Combined with lifestyle intervention, combined with behavioral, intervention, the whole package, comprehensive package. About 10% of people were able to lose 20% of their weight. When you look at semaglutide, which came out, now you're looking at 40% of people able to get into that 20% weight loss category. So that's a big jump between 10% of people getting into that 20% weight loss category versus 40% of people. If you look at tirzepatide, which is coming on the market soon, hopefully for obesity treatment, which is on the market now for diabetes, 60% of people are in that 20% category now. If you look at surgery, 70 to 80% of people are in the 20% weight loss category, even 10 years after surgery. It is the
Wow.
only intervention that we have that long-term data on, right? Because we've been doing surgery since the 1950s, right? So like we've been doing surgery for a long time for obesity, but they have a lot of long-term data on the effects of surgery. And everybody does not gain all their weight back. That is people always say, oh, I have a friend, they gained all their weight back, right? Well, that's good, that's fine. We understand that. But for every friend you have that gained all their weight back, there were 7 other friends that didn't gain their weight back, right? And so again, we have to keep all this in perspective and really educate patients, around what the most effective disease treatment is, because that's what we should do with any disease. Cancer, for example, nobody wants chemotherapy, nobody wants surgery, nobody wants radiation for their cancer treatment, but they do those treatments because they know they're going to give them the best outcome, right? And their doctor says, hey, this is going to be the best treatment for you because this is going to get you the longest life expectancy and the longest, remission, right? And we really should be having those individualized discussions with people, so they can understand, the treatment effects.
Well, given that not everyone wants to have surgery, do you view the new, more recently approved medicines as a substantial advance, and does it merit all the attention it's getting and the excitement that even patients seem to be having?
Yes, I mean it does, right? Because like I said, it is so much more effective, right? So if you look
Yeah.
at that with semaglutide, with 40% of people now getting into that 20% weight loss category, we have always focused on we know that a 5% weight loss even for everyone with obesity in the country would make huge health benefits, right? To lose 5% of your weight. But
Yeah.
unfortunately, when we look at lifestyle intervention studies, these are good lifestyle intervention studies where people are coming in, they're talking with a dietitian, they're meeting with someone weekly, they're even going to sometimes exercise classes and other types of interventions, right? Still, only 48% of people doing that type of treatment will lose 5% of their weight. So, I mean, that's less than flipping a coin, and that doesn't
Yeah.
mean we don't do it for patients because it's important for those 48% of people to get that benefit. But to really sustain that weight loss is what's super hard biologically, right? Because even if you lose that weight with a lifestyle intervention, your body wants to put it back on biologically. And the long-term data we have on people with weight loss shows that they regain half of that weight within the next 5 to 10 years, right? And that's not their fault. But everybody, patients, people, even doctors who or clinicians or people in dietitians, people in medicine, right? Like still kind of unfortunately sometimes, not intentionally, but make the patients feel like, well, if they just did better, they wouldn't be one of those people that gained half their weight back, when actually it's your biology. And these drugs, right, are really attacking that biology at its core. And that's why which is what surgery does too. And so these drugs, right, are replicating the effects of surgery. And that's what we've got better at doing, research wise, right,
Yeah.
is to do that. And it is great, for patients to not have to have surgery, if that isn't something that think their body is able to tolerate, especially, I mean, I've had patients that have multiple surgeries for various reasons. They're like, oh, I just cannot bear another surgery if I don't have to, right? And so again, really sort of having that discussion with patients is imperative.
And for the new drugs that are available now, and some that are, as you said, are going to be available, what are some of the sort of the challenges with access, and what are we seeing in the real world here?
Well, it's very complicated, and that's the challenge. So, I mean, thankfully, Novo Nordisk has been in this business of GLP-1s and obesity for the longest because they started with liraglutide for obesity, which is called Saxenda, and out of all, they have put a lot, I really give them a lot of credit, because as obesity as a disease state, they have done an amazing job of advancing our knowledge, even educating physicians, educating clinicians, saying, hey, this isn't your fault. My little tagline I like to use is, this isn't your character, it's your chemistry, right? And really having patients understand this is not about them. It's not their fault that they are gaining the weight back. This is their chemistry that's driving this. And Novo has done a great job of having obesity educators out in the community, of all the public service type of campaigns, ad campaigns, et cetera. But out of that work, right, they have now created semaglutide too, right? I mean, an advanced molecule on top of liraglutide, which is the way science works, right? We get better and better at what we do, hopefully. And when they launched that, they had no idea that they would have the sort of demand, if you will, quote unquote, that they do. And again, we kind of said, we told you so, we told you so. Like we're trying to tell you there are people wanting to be treated. But there was still this sort of feeling that, because the data would show only 1%, 1 to 2% of people, back before semaglutide, only about 1 to 2% of people were actually engaging in treatment, despite the treatment being available.
Right.
So, they were betting on the fact that, okay, maybe we're going to go to 4%. They weren't betting on the fact that we're going to go to 60% of people wanting to access treatment. I mean, or 30% even, right? Which is 30% of 140 million people in the country is a lot of people. And you can't to physically make, this drug is not necessarily, from my understanding, and again, full disclosure, I am a chemical engineer by undergraduate training. So I do have some, knowledge, advanced knowledge around biopharmaceutical production, which, to make this type of polypeptide molecule is not the same as just making like an aspirin or something, right? Like making something that's just a chemical structure, right? This is protein chemistry that people are doing in order to, get this thing into devices, and it has to be refrigerated, has to be transferred in a refrigerated state. So the supply chain is a huge factor. COVID was a huge factor in the supply chain too, issues. And now it's like the demand, because of all the work that we've all done, Obesity Medicine Association, OAC, all of us have done in order to advance obesity as a disease. We're finally there, and we finally have a good treatment. And now it's like extremely challenging, for patients to get access when they do have coverage, even because, there's the coverage issue. So we can talk about that separately. And then there's just the access issue once you have coverage, which is the fact that you just, can't find the product, and how do I get my hands on it? Yeah, supply. The supply demand is like, they were telling us, like Novo Nordisk was telling us early on, that September they're bringing on new manufacturing lines, so hopefully the supply is going to increase. But then it was like, after a while, just looking at the numbers again, they're like, well, for the unforeseeable future, we expect there to be shortages. So it's just so hard to make so much product, right, and get it out into the hands of patients today with this type of treatment.
Expanding the manufacturing capacity at these companies, it's a capital intense, regulated, it takes months and years to build new facilities. That's
what I said, because I even said, as a chemical engineer, I'm like, we should open we should start a contract manufacturing plant. My husband is a chemical engineer too. We could just start our own plant, and then the people are like, yeah, well, 3 years from now you'll be certified to make product because of all the FDA and CGMP, but thank goodness for those things, right? Because those are what protect us from getting hurt by our medication.
Yeah. Well, in some respects, it's a problem, of abundant demand, as you point out, and eventually, as they learn to improve yields and bring on new manufacturing capacity, they will be able to address that. And so, could you expand a bit more on the insurance side? So let's put the supply side off to the side for a moment. What do you see happening with insurance coverage?
So again, all of our advocacy was working, meaning, we used to see maybe 10 to 20%. So let me preface this by saying one thing. Our main issue in the United States of America is that obesity as a disease state is still not a standard benefit on payer policies. So it's the only disease except for infertility. So if you call infertility a disease, those are the two things that are on carve outs on people's insurance plan. So nothing else is carved out. Like, if I'm an employer and I want to get insurance from somebody, I don't say, okay, I don't want to cover cancer because it's too expensive. So if my employees get cancer, they're just going to have to pay for it themselves, right? We don't carve things out that are diseases. We treat diseases with insurance in our country, right? We have insurance, and that coverage is expected to treat disease states. But unfortunately, because obesity in the early, prior to sort of 1950, 1970, especially, was considered cosmetic. If you needed to lose weight, it was because, again, it was like your fault, and it was just a cosmetic thing. It was a vanity thing. And so that's where there was this carve out, right? And so it allowed employers to decide to add it, but they didn't have to, right? And so because of this now, it makes it so that you have to add it as extra coverage. And so we were doing great about getting employers to add on coverage, like to recognize it as a disease and to add on treatment. So we were up to like 30 to 50% of plans, commercial plans, covering obesity. And then now, though, unfortunately, over the past year or even 6 months, because of all the uptake of GLP-1 use, that's really started to even fall off again, unfortunately, which we feel
Right.
at the society level, at the association level, at the advocacy level, is really the wrong thing to do. We should come together and determine some sort of, as an employer, you could decide what BMI you wanted to use or how you're going to define a sicker patient in order to provide that expensive treatment to that sicker patient. We can do these sorts of things, but just to not have coverage again, just to drop it completely, that's where the biggest, challenge is today, which I would advocate to not do, right? Let's think of some better ways of doing this so that we still provide people with coverage. And again, ideally, if I could accomplish one goal by the time I'm done with my obesity medicine presidency in April, would be that we would have it as a standard benefit. And again, the issue here is that the insurance companies are waiting for TROA to pass, the Treat and Reduce Obesity Act, that has been before Congress, because the big issue is that Medicare also does not consider obesity a disease and doesn't treat it as a disease, doesn't cover it as a standard benefit. So they're waiting for TROA to pass. Well, we've been waiting for 10 years, 12 years that TROA has been on the docket every single year. I've gone to DC several times to, talk to our senators and encourage them to put it into a package of some sort, so we can do this. Well, and, all the other payers are like, well, we're just going to wait for that to happen. But I'm like, come on, let's ante up, United Healthcare, Blue Cross Blue Shield, let's come together and let's say, we're going to treat it as a disease because it is. And it's just good. Everybody might have to pay a little more in their premiums. But everybody across the board spread out, across the United States, I think would be much more, palatable than sort of each company trying to take on that burden.
So if I could follow up on that, because as you said, there's this patchwork, I'll call them potholes, right? Because there's some places, but how do you as a physician and treating patients, how are you managing sort of the process on a day-to-day basis to deal with these potholes of no coverage that you keep finding?
Yeah, Mark, and it's very important, and it's more than potholes right now. It feels more like I don't know, like a unpaved road,
Yeah.
So because like I said, it's gotten sort of exponentially worse. I even hear my colleagues across the country saying that, their staff is quitting because they can't, they're getting so many patients that are angry and yelling at them. And I appreciate, people are, stressed out across the country for various reasons. It's not an easy time right now for any of us, but I would ask people to show some grace to their medical team because they're doing the best they can, because there are a lot of potholes that they have to try to work through. And unfortunately, it costs a lot of administrative dollars that it doesn't have to cost, right? We're wasting a lot of money with both the supply issues, not getting people on standard doses and making sure that they can stay on their treatment trajectory. And we're also, wasting a lot of money in administrative burden. When I was the director of the Mass General Weight Center in Boston, we had 10 full-time FTE equivalents of clinicians, seeing patients in the Wade Center. Obesity medicine physicians is probably the largest group of obesity physicians almost in the country. And we had to hire 3 full-time employees just to do all the prior authorization and manage all the work, around getting these types of medications approved. Because even the sad part, and it gets back to the bias and stigma, is because this is a carve out on insurance packages and it's an add-on to commercial insurance. Even the $10 drugs required a prior authorization, because they're like, oh, you should make sure, because you have this carve out, you should make sure you're keeping track of it, I guess would be the idea, right? So that we're going to have everybody that needs a medication like this, even if it's a $10 or $100 medication, we're going to make sure that they have to jump through hoops to get it, that's what's just ridiculous to me in healthcare. Like, we shouldn't, I have to pay somebody $20 an hour with benefits, et cetera, or more nowadays, especially, to do this work and versus, just being able to prescribe it and get it covered, especially if it's very inexpensive.
Well, that's why we have our podcast. We're trying to find that pathway to the better access. I think a better example might be like the old Indiana Jones movies, where there's that you're walking across the bridge and it's only got a few of the
Yes.
some have a little plank across and others drop 400 feet down. So
I love it.
Maybe that's the analogy. But for you then, because I want to move, if I could, Scott, do you have a question about demand, production, supply, coverage? Because I want to move also into sort of the patient side of things real quick.
Well, I do wonder what's given all the potholes and the sketchy coverage, I'll say, what do you see patients doing when they don't have the coverage? What happens to them?
So that should, we could probably do a whole separate podcast, because I do think we are doing the country a disservice right now, because we are not being as forceful as we could be around regulating an industry that's cropped up now for patients that are getting access to product that is completely unregulated and unmanaged, which is your compounded drugs. So the compounded drug market has picked up on this and is making compounded treatments that claim to be semaglutide. They are semaglutide in many cases, meaning if you take the drug and you put it through a chemistry analyzer, right, a mass spec or something, you can tell that it's the same molecule or looks like the same molecule as semaglutide, but it's not the same. It's not the source compound. The only company who can make semaglutide is Novo Nordisk, and Novo Nordisk is not selling their semaglutide to compounders. So, this product is completely what I call bootleg, right? And and patients are taking it. A lot of my patients, I'll see patients in the office that have been taking it, or the patients that come in and I'm getting them on real product, on real drug, they're always like, oh, my friend's taking this stuff from, down the street.
Oh.
There's no dosing regulation. So frequently it's given to patients in insulin syringes that are not labeled at all. They're just like a baggie full of syringes for the patient to inject once a week. But it's a huge harm. It's the largest unconsented, uncontrolled human research experiment that we have ever done in this country, and it's happening before our eyes.
Wow.
Without any kind of. The FDA made a comment about it. They stepped in and made a statement about it, right? That you shouldn't. A warning to patients, obviously. But I really think we should be, doing more, because back to your question, Scott, what do people do? Well, a lot of them
Right.
turn to this sort of black market, if you will, which isn't even black market. It's legal. Like, people can advertise, and even some of these advertisers are using,
Right.
they're using the product. Like, they're using, Wegovy. So they have the Wegovy on their website. They're using the syringe, like, to advertise,
Oh,
but they're not even
yeah.
giving people that product, right? So consumers. I meant from a consumer, like FTC or something, right? We should really be, from a consumer safety standpoint, it's a big issue. But on the other hand, I'll say, we still use our older agents, right? Our older agents still provide, increased weight loss and increased health benefits, right? So quality of life and other types of factors that we look at, not just weight loss, right? We're not just talking about weight loss. We should also talk about, we're talking about obesity disease treatment. and getting patients a different outcome than they have today. And we can do that with our older medications as well. And those medications are available a lot of times generically. So patients can afford, patients can pay, cash, for example, for phentermine, or they can pay cash even for the branded products that are on the market that combine phentermine and topiramate, which is Qsymia. Has a cash price of around $100 a month. So for some patients, they're able to afford that. Now, for our biggest issue, right, in the country too, is this huge disparity issue we have, which is we have a lot more obesity in our patients that have higher social determinants of health, and it affects them greater. Yet they're also the people that have the least access in a lot of cases, which is also very challenging. As a nation, that we need to really take note of that and try to fix it.
Well, on that note, what do you think steps could be taken by the government, by payers, by physicians, by the manufacturers, all the other stakeholders? What can we do to help with the disparities that you see in the market?
Well, one thing we've been doing, quite often with the Obesity Medicine Association and our advocacy committee is really advocating for coverage with Medicaid. So Medicaid, as you may know, I believe, and I don't fully understand it, you guys probably know better than me, but gets special pricing too on medications often. Right. So they can negotiate different rates, is my understanding, that might be quite a bit cheaper, than even what a rebate that might happen on the commercial level. So there's been a lot of states. There's now, I think we're up to 16 states in the country that offer obesity treatment, offer anti-obesity medication as a treatment path, for patients that are on Medicaid. So that's a huge accomplishment over the past even 5 years. That's definitely taken a significant ramp in the upward direction. And so I encourage clinicians of all sorts or patient advocates, to really advocate at the state level to add, anti-obesity coverage, to the Medicaid plan, because they have to do that in a special way because Medicare doesn't allow for it. So they have to get a regulatory override. I can't remember the name of that thing that they have to do, but they have to, get approval as a Medicaid, in order to offer that service. So we really try to advocate for at least that to happen. But I think, we need even broader sweeps trying to get patients access to these treatments that really could use it.
Yeah, and how about the other stakeholders, Angela? Any other roles for government or for the manufacturers or advocacy groups? Any other ideas about what could be done here?
Well, I would love to see the cost come down. That's meaning the big thing, right, of all these discussions is cost. That always comes down to it costs too much. Well, we don't say that. We don't say that about cancer. We might talk about it, right? But and try to manage it. Certainly, we shouldn't just go spending money willy-nilly. But at the same time, why are we? Again, it goes back to some of the bias and stigma that we're saying, well, it costs too much, I'm not going to cover it. And I think if we could really, though, advocate at the, I would love to see I'd love to see what happened with COVID, right? I would love to see obesity today at the federal level be treated like COVID. Right. And let's get like Operation Warp Speed. So we need like Operation, I don't know what we call it, anti-Hunger Games. I don't know, because like right now it's like the Hunger Games. That's what we joke about. People go out there and they have to try to find their medicine, and it's like fighting for this, that, and the other. It's like a war out there, right?
Right.
So I'd like to see, more contract manufacturing, more like, how come we can't get Novo to work with the government and open up a bunch of, I don't know, there's got to be facilities that can maybe make it, and get approval to make it quicker, and we could actually, move the needle a little bit in terms of supply. Because right now, when you have so much demand and not enough supply, there's no impetus to lower the price. That doesn't, economically, nobody does that.
Yeah.
Well, I have my wonderful partner here who's been an expert and been inside the conference rooms discussing this. But as an outsider, I think there's a couple of things we've seen from dealing with patients, and that is that even if you lower the price, the demand is so great, the insurance companies will still not cover it. they're still going to find ways to say no, and put up more barriers, all the other things. I think what's amplified the discussion around price is the lack of coverage, and the fact that so many people now are considering paying this out of pocket, because I think the other side that's not getting discussed, as you said, is the benefits of being on this treatment. Imagine the cost of the drug that it is today, and just the recent study about the improvement on the heart, the reduction in, again, you guys are both physicians, but it's dramatic.
Right.
You're talking about, it could change everything about healthcare and truly be one of the things that lowers healthcare costs.
Exactly. And that's why we should do it. I think, for those, like, the right reason. I know it sounds very, I don't know, sounds very altruistic or something, but I mean, the point is, we are, Scott and I are physicians, so that's kind of in our DNA, to be caregivers. But the thing is that, we should do it for those reasons, right? A 20% reduction in major adverse cardiovascular event. What's the price that you can put on a stroke for one patient, right? That's what we're talking about here. And someone did the analysis recently. The data has not been released, so you can't do the exact analysis, but they made up the numbers, at least based on we know how many patients were in the trial. We know what the risk reduction was. And even then it to prevent, the analysis that was done, at least, again, this is on data that's not been released, so we don't know the actual number needed to treat, but the number needed to treat there was 60 some people, like 64 people or something, to prevent one stroke, heart attack, whatever. That cost is like 1.1 billion, depending on what time period you look at. The other thing that drives me nuts too, though, is people do these cost analysis on patients being on these drugs for the rest of their life. However, the cost is going to come down over time. No one's accounting for the fact that in 5 years, we're going to have oral or forglipron that's hopefully going to cost, I don't know, $150, $200, because it's much easier to make and doesn't have to be cold shipped. It doesn't have to be put into individual plastic pens, and so once we have that, right, then the price is going to come down. So, these patients aren't going to be on this drug, so to speak, probably for the rest of their life. Maybe, certain people, right, they'll still be, I think we still need a lot more things in the market, because the more, we just have so many people to be treated.
Well, and I've read Peter Kolchinsky's The Great American Drug Deal, where he also talks about the fact that, you've got the generics, which never gets factored in, right? Like these drugs, like you said,
well, 15%.
in 5 years, 10 years.
15% of patients will lose 20% of their weight on Qsymia, on phentermine topiramate. It's a good drug. Now, I have my patients with severe anxiety disorder on multiple medications with kidney stones. They can't take Qsymia. So I can't give it to that person. But I have a 25-year-old patient with no comorbidities that can clearly take Qsymia, right? If that person had that available to them. And so again, I think having my perfect world would be, with insurance companies, would be included as a standard benefit. Don't make everybody else decide who's going to pay, right? But everybody pays. And then, make any of these cheaper generic or even cheaper drugs, like even Qsymia and Contrave, which are much cheaper, make them readily available without prior authorization, so that, more people can get access to treatment, at least see if they're one of the 15%. And then you have, what is that? That's 20 million people that don't have to take a $1,000 a month drug for the rest of their life.
If I could just, Scott, I know I've been talking a lot, but just real quick, because we've talked about demand, production, supply chain coverage, but I think also there's a challenge around getting these patients started on treatment, right? Isn't that correct? Can you share more about the challenge with dosing and titrating these drugs?
Yes, so it is a challenge just because of the supply, right? And it's a challenge even without the supply, because it's also a challenge even before we had supply issues. Unfortunately for some companies, we have to prior authorization each dose. So, patients are notorious for, I'm a patient too of different sorts, right? You're notorious for, on Friday when you take your last dose, you call the pharmacy because you expect to get it on, before next Friday, right? Because it shouldn't take a week to get a medication. But you don't realize that you have to do a prior authorization, right? Because, even at at our space with 3 people, we were still having trouble setting up a tracking system. There's no inherent tracking system. Like we had to create like an Excel spreadsheet to like try to track, when the person's next prior authorization was due. We waited on the pharmacy to let us know that the patient needs a prior auth, but then the prior auth takes another week. So now the patient has missed 2 doses, which isn't a big deal if you're taking lisinopril or something. I mean, maybe it is. You don't want to have a stroke, from your hypertension. But the point is that you can just go back on your lisinopril and you'll be fine. But with these medicines, you have to stay on track and you have to stay, you can't just miss doses and go back on your same dose. And so again, there's a huge coordinational challenge just with all the administrative work that has to be done around getting patients these medications.
Yeah. Well, Angela, just one final question from me. I'd be interested in your take on the manufacturer support programs. You mentioned you gave Novo Nordisk a lot of credit earlier. I know they have copay cards. I know that they offer a $500 discount to people who are completely uninsured. Have you and your patients been able to take advantage of those, or do you have any changes or differences you'd like to see in those?
Yes, I do. I mean, we would all like to see, unfortunately at this moment, Novo Nordisk and Eli Lilly do not have patient assistance programs for obesity, anti-obesity medications. So, for example, there's no patient assistance program for Wegovy, like there is for
the free goods.
Yeah,
programs.
the free programs. Yeah. We've been telling them that for some time, that we'd love to see we would even have loved to have a liraglutide, especially as liraglutide is going to go generic, and now obviously there's a liraglutide shortage too in Saxenda. We have a hard time getting patients Saxenda even. So, I think because of all the supply and demand, it's been hard for them to even run some of those programs because it's hard to, but we definitely have been telling them over and over that we'd really like to see a true patient assistance program, for our anti-obesity pharmacotherapy as well as the coupons.
Yeah.
The coupons are okay, but really, when you get $300 to $500 off of a $1,600 medication, I mean, most people still can't afford that, right? And so it really isn't, a viable option, for most patients. I do have a lot of my patients using these types of savings cards to get, again, $500 off a $1,000 drug, so they're paying $500 a month for a drug. But those are really the top 1% of the country from a earnings potential. Those are not people who have, you have to have a fair amount of disposable income, to be able to sort of afford, that level of a monthly cost.
Yeah. Okay. So Mark, should we wrap up with our usual magic wand question then? So if you could imagine for a moment, Angela, you had the magic wand and you could wave it and do one thing to improve access for patients in this area, what's your prescription for better access?
Well, as I said earlier, I think that would be that it would be a standard benefit on all commercial insurance policies, that Medicare, TROA would pass, right? We would accept obesity as a disease and we would cover it in our programs across the country that help to insure patients, right? And that coverage would be available. That coverage would be where, again, the lower cost alternatives they have no, prior authorization, no access, no requirements for trying to jump through hoops, that more patients could get on those types of treatments. And then we could fix or worry about, how are we going to have good stewardship around our GLP-1 prescribing, who is going to be the patient that gets, access to this type of treatment. And then we could actually really move the needle on our obesity numbers. And we would, I think, see that national obesity trend that keeps getting greater and greater every year, including 20% of our adolescents, right, that continue to see obesity bigger and bigger every year. I mean, we would actually see that we would see the curve bend if we could actually do that. And that would be my magic wand.
That's great. Angela, if I could, though, we're going to release this distributed during Obesity Week 2023. So if we could, what advice do you have for patients, like someone who's out there worried or challenged? What advice do you have for them?
Well, I do have advice there too. I'm really glad you asked that, Mark, because I think if the 140 million people in the country got mad, right, about this issue, if they're listening today And they really, if 140 million people marched on the Capitol, I mean, it would not be, there would be some people taking notice, right? I mean, even if a million people, marched on the Capitol, right?
Right.
500,000. I mean, how many Susan G. Komen people march on the Capitol? I don't know how many it took,
Right.
in order for Medicare to say we're going to keep the mammogram going, right? Like we're not going to take it away,
Right.
right? But we need we need patients to come forward. And because it is such a bias, it's such a stigmatized disease, an internalized stigma, right? I appreciate for years people have been told just do better and you will be better, right? We need to get over that. People need to rise up and say, write your congressman, write your people, go to the, say, we're not, go to your insurance company, and go to your employer, right? And say, we're not gonna take this anymore. You gotta give this to
Right.
us. You have to have some access to treatment. And that's not just like a subscription to the gym, or we give people subscriptions to the gym and these wellness programs. We give people access to Weight Watchers. Nothing against Weight Watchers, is an excellent program, but that's not enough. We're not moving the needle. We've been doing that for years, and that isn't making a difference. If we do comprehensive obesity care, which even Weight Watchers has started to do now in terms of adding anti-obesity, an arm, to their company, right? And we need to really sort of have people go forth and don't be afraid, don't be stigmatized, right? And come forth and tell your stories and get out there, because even I tell you, even my best, even patients who are such great advocates and they're great successes with their weight management, they hesitate to shout from the rooftop, right? Because it's such a,
Right.
it's such a stigmatizing disease. It's like mental health 20 years ago when, people
Right.
had mental health issues, and now we have NAMI and all sorts of advocacy groups that really support for change for mental health. And it's still stigmatizing, of course, a little bit. I mean, obviously, but it's not near as much as it was before. And so we really need patients to come forward and say, this is really an important issue for everybody, not just the 1% of people that can, fight hard enough to get access. But that's what the other thing I would say is fight hard for yourself, right? This is an area where you have to stay persistent and you have to really sort of do a lot of your own care navigation, and don't take no for an answer, right? Like in a
Right.
nice way. Don't get mad at your healthcare team. But I mean,
Yeah,
because
yeah.
sometimes the answer is
Right.
no. But then what I meant is then you got to go back to your employer, or you got to go back to your
Right.
payer, you got to go back to your government. That's what I mean by don't take no. Because sometimes, unfortunately, we have to say no because we can't get it covered. There's nothing we
Right.
can do.
You're just delivering the bad news. You didn't
Right,
Yeah.
you didn't make those decisions.
right.
Yeah.
Well, Angela, thank you. Thank you so much for joining us today. This was such an incredible episode, and we're so appreciative of your time and your insights and your advocacy for patients and what you're doing to make a difference. So we're really honored to have you on our podcast. So thank you for what you're doing.
Thank you.
Thank you so much for having me. It's been a pleasure. And thank you
Yeah.
for what you're doing in terms of raising the awareness here, because this is very important.
Well, we're trying, and we're also trying to, educate. What do we say, Scott? Educate, advocate, and inspire.
Right.
So,
Love it.
how about that? I'd like to say I came up with that one, but I didn't. It was my partner, Scott. So, Scott, do you want to do lessons learned today, or you want me to jump?
Two things it's really struck me. One, just what a pleasure it is to see thoughtful, caring, passionate physicians like Angela in action, and I'm grateful that we have doctors like that available to us in our country. And then secondly, just what a mismatch our healthcare finance system is for public health problems. This is arguably our largest public health problem in the nation. We spend $250 billion a year on the complications of obesity. It's
Right.
not in the individual best interest in the near term of any insurance company or employer to care and manage, pay for this stuff, but it's in all of our best interest to do it in the long run. And somehow it strikes me, I like Angela's idea that we were able to get our act together for COVID, we need to be able to mobilize a public health attitude that would get our act together for this kind of thing for the long run, and do what we all know is actually in our own best interest in the long run. So,
Right.
Pull it out. If we can't mandate everyone to cover it, then pull it out, cover it at the national level, pay for it with taxes or, whatever. Just work with great clinicians to decide what the right coverage policies are, and then fairly implement them, broadly, and do the right thing for patients. In the long run, we'll all be glad we
Right.
did.
Absolutely. Totally agree with both your points. I would add also, on the patient side, I loved what she said, that it's not your character, it's your chemistry.
Right.
And that should be on every billboard out there as we tackle this from a as you said, from a public health perspective and from what everybody's doing. So this is unfortunately, something in which it just wears on, I'm sure, people that have obesity over the years and
Sure.
continues. And so they've been told, for so long that it's their fault, it's their fault, it's their fault. So it's not your character, it's your chemistry. So I think that should be a bumper sticker and a billboard.
Right.
The other thing I think that's important is sort of what you said, but looking at it from a different way, which is that I think all stakeholders need to realize that we have a train wreck coming, right? Like even the FDA came out with a very weak statement about compounded drugs, but there's so many things that are going in this area, so many demands on patients that are taking over the burden from being responsible. They think they have insurance, and then there's something to treat them, and then they go to get coverage. Oh, and it's not a standard benefit. Like all of these things combined, the supply chain challenges, all throughout every step of this way of what's going on, I see it as a potential for a very combustible situation that people could get harmed, and that would be unfortunate. So I think we have to put a lot more into this. Hopefully, Obesity Week 2023 is a step in that direction.
Yep.
But I think this is early days, and I think there's a lot more that could be done.
Yeah. Well said.
Well, with that, I don't mean to end on a heavy note, because what you are doing, Angela, is amazing. But this is critically important, and it is in the headlines. And as Scott said, thank you for what you're doing. And if I'll wrap up by saying, and thank you to my partner Scott, Scott for once again being the best co-host out there in the podcasting world. And from our point of view, you're going to notice some new things this fall with our podcast. We're going to have more links so that we'll be able to get access for patients to be able to seek help and find resources. We'll have information for the Obesity Medicine Association and other groups. So I think this is an important topic. I wouldn't be surprised if we need to be back here next year talking about this one as well.
It's evolving. Yeah.